Welcome back, everyone. I hope that you enjoyed the breakout sessions, our first parallel sessions of the conference. I'm glad to see there's still energy at this time of day. That's wonderful to see. We're going to get started with our final session of the day. Our final session will explore what drives or derails policy impact, drawing on real cases of success and failure. And to lead this conversation, I'm happy, Dr. Joynt Maddox is already here up on the stage. I was going to invite her up, but we are ready. But I'm happy to introduce Dr. Joynt Maddox. She's a cardiologist at Barnes-Jewish Hospital, a professor at WashU School of Medicine and School of Public Health, and co-director of the Center for Advancing Health Services, Policy, and Economics Research. Over to you, Dr. Joynt Maddox.
Thank you, and good afternoon, everyone. It is truly an honor to get to share the stage with this amazing group and to be part of this incredible conference, and I appreciate you all being here and hope that you save some energy for this time of day. And we are going to do our best to save quite a bit of time at the end to make sure we get questions and sort of have a rolling conversation, so be thinking as we go about things that you might want to ask the panelists. So our job this afternoon, should we choose to accept it, which we have, is to try to kind of tie together what we've heard today and talk about how to have the policy impact. So we've heard a lot today in the opening panel. We heard we're in a critical time for hospitals and health systems and health. We heard in the People's Voice panel that people's opinions matter and that data matters. And we heard in the evidence to policy panel that communication matters, and it turns out politics matter a whole bunch. And we heard in the keynote that location matters. And what we're hoping that this panel is going to do is sort of close out the day with experts across the continuum of evidence generation to really policy implementation, and take all the things that we've heard that matter and talk about how we actually do it. So we're going to go from evidence development, from evidence development to policy sustainability. It's going to challenge me at this time of day to speak all these big words. And I'm going to introduce the panelists briefly and then sort of let them each have a moment to talk about their topic. So first, we have Dr. Lisa Hirschhorn, who's a professor at Northwestern, physician in infectious diseases and director of the Ryan Family Center for Global Primary Care. And Dr. Hirschhorn is going to talk about the strategies needed when implementing interventions to produce evidence that has the potential for policy impact. So when you're first doing the thing, how do you need to think about doing the thing? Oh, actually, I'll introduce everyone. Okay, you can see everyone up there. I'll introduce everyone first. So then Munira Gunja, who's a senior researcher in the International Program in Health Policy and Practice Innovations at the Commonwealth Fund, is going to talk about how evidence gets policymaker attention. Doug Luke, who's a professor at the Washington University School of Public Health and runs the Center for Public Health Systems Science, is going to talk about the science of translating research to policy. Ryan Barker, who's the Chief Program Officer and Vice President of Policy and Advocacy at the St. Louis Integrated Health Network, is going to talk about navigating the policy process, sort of translating research to policymakers, big P and little p policymakers. And then Blerta Maliqi is head of the Quality of Care Unit and Patient Safety at the WHO, is going to take us to the biggest picture of how do we actually implement these policies and make sure that they're sustainable. So that's sort of the arc. Be thinking about your questions, and I'll hand it over to Lisa.
Thank you. Oh, wow. How exciting. It's a very good strategy. So I was asked to sort of start this discussion and sort of thinking about, when we start to think about, generating evidence with a goal towards influencing policy, sort of how do we think about doing it? And I just actually have to give credit to the session I was just at, which was about the World Bank, and sort of was scribbling some ideas, as well as the panel that was before about sort of policy. And I think the way that we need to start thinking about it is a series of questions that we need to ask ourselves as we're beginning to design, whether it's our study, whether we're calling it research, whether we're calling it evaluation, whether we're calling it quality improvement. And I think the first question is, who's demanding the evidence? So is it the researcher, I have this really cool idea, I have this app that I want people to use, or is it actually at the national government, Is it the country or is it the donor? And so one really exciting sort of success that I've seen from this is actually working with Mark Huffman and DK Oji, who may or may not be there. There they are, which is the national sodium reduction, which came from the government saying, here's our strategy. And so the research is, well, how do you actually implement that strategy to be able to actually change policy? And so I think that's quite different than if you're coming in with an idea, for example, HPV vaccine, which has all kinds of other contextual factors around it, which may be harder to do and may not necessarily be a priority of the government. The second is what evidence exists and how much of it, and what's the demand from the government. And I was involved in some work understanding exemplars in dropping under 5 mortality. So these were countries which have been more successful in dropping under 5 mortality. And they all had big sort of data consumption, but the data that they demanded to actually take something that was, as we call it in implementation research, the thing, the vaccine, was actually quite different. So Rwanda basically said, well, it works in the region, let's just get it out there. And Nepal, on the other hand, said, well, it may work in the region, but we need to have actually primary effectiveness data here in our country. And so they spent a couple of years actually doing that. So some of it may be you think that the evidence is perfectly good enough to actually move on, but it has to be who's consuming it and what the policymakers want. The third thing is how fast is it needed? And that really needs to drive, therefore, the design that you do. And there are things about what we call fast change versus slow change. So some things are very easy to get into place, anesthesias being a really good example versus antisepsis. But one of the sort of examples that I know of working with a colleague who was in a country, and she had to make a decision about like how to actually use additional money they had to support street vendors during COVID. And she went to the local university, and the local university says, oh, we can do this like really thing. It'll only take us 6 months. And she says, well, I need actually 2 weeks. And so she actually had to go to a very different set of people who do more evaluation, I will not named company that was actually able to give her, a good enough guess at what to do in the next 2 weeks. So figuring out what's the time frame on this in terms of how fast is it needed. The other thing is sort of thinking about the thing itself. What does it bring along with it? So if you're, for example, trying to get measles vaccine in, or even malaria vaccine, that's actually quite different than if you want to do HPV vaccine or misoprostol, for example, as a way of for home-based delivery, which is an intervention which reduces postpartum hemorrhage and therefore can save women's lives. And if you sort of look at some of the evidence of what was needed to do that, and there's some very nice work that was done in northern Nigeria, where they realized that if we want to get misoprostol out there, we had to sort of accommodate who were the gatekeepers and who were the opinion leaders in terms of who was going to give permission for somebody to actually give the mom misoprostol to take so that when she delivered at home, which is a whole nother question, how to do it. So I think it's really sort of thinking about the context in which you're working, the evidence that's needed, the time frame over what it's actually needed, and then finally thinking about what is it that comes along with that in the contextual factors. So I actually originally came from HIV, so in the 1980s, where there was a huge amount of stigma, there still is. And so if we think about that as a really good example and look at the uptake of evidence into policy over the time frame of the HIV epidemic, I think it has some really important lessons for us. So when we think about when some of the first medications came out, they didn't immediately go into policy, some of them for a very good reason. But some of that had to do with the fact that in some countries there was a lack of belief in them. So that took a number of years to do it. And then some of them, it was actually there wasn't enough funding to actually do it. So when we think about evidence into policy, we also need to think about sort of the details. And there was really interesting work from Samoa, which was looking at the hypertension cascade. And then it was followed up with funding to be able to get it into policy and then into practice. If we continue along the HIV sort of continuum, there was the next thing, which was sort of prevention of mother-to-child transmission. We saw a little bit quicker uptake because that was something where people could see very quickly what happened with it. Babies were born positive or negative. Then when what we call test and treat, which is essentially get everybody who's tested onto treatment, that was taken up very, very quickly because the context had changed. There was funding available from PEPFAR, and that went into policy in many, many countries very, very quickly. I think we're now at a tipping point because we now have very effective prevention with lenacapavir, 1 shot every 6 months. But is that going to actually go into policy? And is it going to go into policy for all the people the key populations, the people most at risk? And so really understanding what is the evidence that's needed, not just for the effectiveness of it, but how do we actually get it into practice? How do we get it that's going to be acceptable? and how is it that the people who ultimately need to say thumbs up or thumbs down from policy, from funding, are going to actually believe that it works. So I think there's a lot of lessons in terms of how we think about it. And then finally, we need to be very careful about the strategies that we use. So simply showing effectiveness and getting that into policy is probably going to fail as we go down this cascade from evidence into policy. And so I think the idea is that we need to understand not just what it is that we're trying to do, but how do we do it, and how does that need to change depending on sort of where you are and what country you work in. So I work in something called NEST 360, which is for reducing mortality and morbidity in small and sick newborns. And when we're talking about sort of rural Malawi versus urban Lagos, those are very, very different contexts in terms of the strategies that we might be using. So keeping in mind that when we actually tell people the evidence and the cost of doing it, it's not just the thing, but it's the strategies that are needed to do that. Otherwise, we'll be very successful at getting evidence into policy, and then it's going to fail as we go down our pathway. So I'm going to hand the mic over now.
Hi, can you hear me? So again, I'm Munira Gunja. I'm the senior researcher at the Commonwealth Fund and our Promoting International Learnings and Exchange program. So when we think about policy and impact at the fund, it's really important to understand how the organization is structured. So we are a health policy organization. We're in New York City. We have a mission of promoting a high-performing, equitable healthcare system for all Americans. And so that's really our guiding North Star. Everything we do is about trying to achieve this mission. So then under that, we have three main areas that we really focus on. The first one is our coverage program. So how do we get all Americans health insurance coverage? The second one is cost. How do we make sure health insurance is affordable? How do we make sure that we are pricing services for the value that they're actually providing? And how do we make sure that prices don't continue to go up and up and up? And then the third one is our care program. So really making sure that people have high quality care, but that we are also investing appropriately into primary care, making sure that our providers are being paid what they should be being paid. And then underneath that, we have our international program, and it's really a cross-cutting program. So we take all these big priority areas from the cost, coverage, and care programs and try to understand what countries are doing this really well. So whether that's at a high level, a country has a really robust health system, or in general, or maybe a country does this one thing really, really well. And what can we learn? What can we take from that country, adapt here into the US model? And so when we think about impact, as we heard a lot today, we're really good at the data, we're really good at generating evidence, but then how do you, of course, take it to the policymaker? We are a very small organization, we're about 45 people, but about 10 people are dedicated to our communications team. So anytime we have an idea for a publication, we really think about how do we disseminate it, what type of publication should it be? Should it be a long issue brief? Should we really use social media to get the word out? Should it be a blog post? What does the timing look like? Is there going to be a policy window when we can really get the word out? So we do all of that for every single piece of evidence we generate. And then we also have our federal and state health policy team. So they're based in Washington, DC, and they're the ones that go to Capitol Hill, they go to state policymakers, and they know really who are the people on the ground to contact. So not every single thing I produce is going to get into the hands directly of policymakers in DC, but we are very strategic about what types of publications. So for example, maternal health work may go into the hands of the right people on Capitol Hill that are really invested in improving maternal health in the country. So we think about every single publication in a way that actually will make sense and will actually be as impactful as possible. I'm going to stop there, but I'm happy to take questions after everyone goes. Thanks.
Great, thanks. Good afternoon, everybody. I'm Doug Luke, and I'm representing the Center for Public Health System Science here at WashU. And at our center, we do a lot of different things, but the intersection of policy science, system science, and implementation science is what has allowed us to learn something about what's the right way to do research on translating scientific research into policy. And today I'd like to make just 3 points. And these 3 points taken together are really an idea of how we need to shift our research, especially if we care about how policies lead to impact. So the first point is all policies are local. The second point is unpacking the black box of policy mechanisms. And the third is the need to look further down the road to assess policy impacts. To set this up, so we've heard a little bit about both the importance and some of the challenges of developing evidence to support policies. This is critical, and it's a first step. However, this is just the first step. Policy effectiveness is a necessary but not sufficient condition for policy translation and impact. For example, and I'm going to use examples from our tobacco control research. For example, we have known for decades, maybe even half a century, what policies work to reduce tobacco use, raise prices, implement broad smoke-free policies, and restrict the ability of the tobacco industry to market and sell products to vulnerable groups such as kids. Despite this knowledge, despite this old knowledge, we have a huge implementation gap. Why is it that in New York City, the tax on a pack of cigarettes is over $5, whereas here in Missouri, it's 17 cents? The science is the same in New York as it is here. It's a huge implementation gap. So if we really want to have an impact, we need to understand how policies are translated, disseminated, adopted, and sustained over time. So to my 3 points, all policies are local. You've all heard the phrase, all politics is local. Well, it's the same for policies. Traditional public health policy research often pays very little attention to context, but context matters. An evidence-based policy in tobacco control, as one example, is restrict the ability of tobacco retailers to sell products if they're close to schools. The idea is protect the kids. However, and it's an evidence-based policy. However, the effectiveness of this policy varies dramatically across different types of communities. In dense urban cities like New York City, this policy can greatly reduce the density of retailers and thus subsequently reduce tobacco consumption. But the same policy will have little to no effect in rural areas or in spread out suburban areas because there simply aren't retailers near schools to be affected by that policy. So in this case, the geographic context matters. For another example, consider, let's say, San Francisco compared to St. Louis. We could implement the same policy in both cities, but the effects would be different because San Francisco already has a lot of effective tobacco control policies. So adding another policy on top of that pile of good policies won't have much of an effect, where one good policy could have a major effect in St. Louis. So that's another example of how context matters. Essentially, in our research, we need to take context seriously and tailor and adapt policies for those contexts. So that's the first point. The second point is what I call opening the black box of policy mechanisms. In addition to knowing if a policy works, which is usually our first thing, does it work at all? Then we need to understand why it works. And in fact, sometimes we never get there. We know a policy works, but we don't really understand how it works. Policies generally work, at least in public health, by altering physical, social, organizational, legal, and so on environments that then in turn shape behavior and health. In tobacco control, typically the way these policies work is by making it harder and more expensive to obtain products. It's not that complicated. In our own work, we use computational modeling, things like agent-based modeling, to show community leaders and policymakers what their cities look like now and what they would look like after a policy is being implemented. So for example, in the previous example of retailers around schools, this is what the map of retailers looks like now. And after we implement this policy, look, these tobacco swamps, which is what we call when there's a lot of tobacco retailers, are drained and cleaned up after this policy has been implemented. Finally, my third point is we need to look further down the road to understand policy impacts. And this has already been hinted at, but a lot of times it takes time to see what a policy is doing. For as thinking about another tobacco control policy, smoke-free policies, there are short-term, medium-term, and long-term effects. So when you implement a new smoke-free policy, the way WashU years ago went to a tobacco-free campus, an immediate effect is you reduce the exposure to secondhand smoke. A second ripple effect is the cessation rate goes up. People don't want to walk off campus and go to the sidewalks. That's what they did. They went out to the border of campus and started smoking, and they didn't want to do that. So they actually quit because of that policy. For this example, though, more importantly, then years later, what ends up happening is, first of all, there's pushback by the community. They don't like this policy. And then there's acceptance. And then the norms and the culture change in your community. Imagine if any of you went on a plane and somebody lit up next to you, or you went to the doctor's office and your physician was smoking. Well, that happened while I was alive. I was pretty little. But our norms have changed because of the long-term impacts of policy implementation. And the problem here is that's not the way our research is funded or our research is structured. So maybe we should change that so that we can look at these impacts over time. So I'll finish. I'll stop there.
Thank you, Doug. Good afternoon, everybody. I am Ryan Barker with St. Louis Integrated Health Network. I'm going to start out with my 3 points and then give an example about what I want to weave in those 3 points. So first, let me tell you a little bit about St. Louis Integrated Health Network. We are an intermediary organization representing 90% of the safety net providers here in the St. Louis region. So our 4 federally qualified health centers, Affinia, People's Health Center, Family Care Health Center, and Care STL, BJC, SSM, WashU Medical School, SLU Medical School, the City Department of Health, and the St. Louis County Department of Public Health, along with their brand new FQHC lookalike clinics out in the county. We really have a dual purpose. So one, as an intermediary for those organizations that represent the safety net community, working with them to better coordinate, communicate, to better serve patients. But then a part of our role is also raising the voice of the community into those discussions. And I bring that up because my 3 points about policy and working with policymakers. So one, relationships. 2 is community and really representing community in policy and the research you're doing from the very beginning. And 3 is policymakers as a big umbrella, because we often think of policymakers as the politicians, but policymakers include a lot more people than just the elected officials, and it's vital to the work in the policy arena. So the example I want to give, so I actually spent 21 years at the Missouri Foundation for Health, which is a philanthropy here in Missouri, and much of that time I ran their policy and advocacy shop. So a lot of the work we did was policy research, putting out fact sheets, one-pagers, working with policymakers. But we also, very blessed as a foundation, we were able to fund stuff and work with community groups to do that. The example I want to give is a group called Missouri Appleseed. And they really, one of the issues that they were working on that really raised from community was here in Missouri, there were a lot of concerns about the health of prisoners. And if any of you are researchers in that space, the health data that comes out of prisons and jails, it's often a black box. You just can't get in, you can't get it. But they were hearing stories from people coming out of prison and jail about horrible health issues. And the foundation, and this is relationships. So one, establishing relationships with folks before you've done your research, just that are interested in your area of research. So the foundation we had a relationship that we had cultivated with the director of the Department of Corrections. So at the time it was Director Precythe. And we helped introduce Missouri Appleseed to the director because Missouri Appleseed was specifically interested in Missouri's 2 women's prisons and some real health concerns that they had been hearing about that were stemming from really poor quality feminine hygiene products that were being offered in the prison. And so we helped navigate that relationship, make the introductions, and the director was actually really interested in the issue because they were paying a lot in healthcare costs as the Department of Corrections. And so she let Missouri Appleseed come in and do qualitative research, interviewing women prisoners, and talking to them and gathering information that way, but then also gave them access to some of the data. And what they found, very high level, was the Department of Corrections was providing, one, they only provided sanitary pads to women, and they were of such poor quality that women were using 4 to 5 pads, or they were making their own out of t-shirts, out of rags. This was leading to lots of infections, as you can imagine. And so what the research found was that if you spent a little bit more on higher quality feminine hygiene products, including tampons were not available, they were not given out in the prison at all. But if you spent a little bit more money, you actually would save so much on the healthcare costs on the back end. It seems very common sense, but sometimes that's what policy change is. But because we had that relationship and Director Precythe was really interested in this, she then became a champion. So Missouri Appleseed did, and she is a policymaker. She's not elected, she's appointed by the governor, but we often forget that executive branch departments have a lot of power in terms of policy change. Now, she ended up, usually they say, at least in Missouri, you have to get an idea introduced and in legislation at least 3 years before you're going to pass it. It just takes that much time to build up interest and momentum. I will tell you this issue was fixed in 1 year. Now that happened for multiple reasons. One, Missouri Appleseed did an amazing job at finding a legislative champion who very purposefully was a Republican and a woman to take on this issue within the Missouri legislature. And then 2, it was a very easy fix. And the cost was so minimal, but was impacting women's health at such a crazy level that it ended up passing in 1 year. Part of that was because, if you are familiar with Jefferson City and the Missouri Capitol building, a female legislator standing up and talking about feminine hygiene products, most of the males just wanted her to stop speaking and they would do whatever she wanted. But literally the fix was to add some money to the Department of Corrections budget, and within that same year, they got it fixed. But it's a great example of just relationships, the voice of community, and really thinking about policymakers, because Director Precythe was the champion, she also worked with the legislative, the representative champion to get this done. So 1, speaks to the power of women, but 2, speaks to the power of relationships that already existed when you're trying to get policy change done. And I'll stop there and we'll cover more later.
Well, I think I come to the end because they gave me the task of implementation. Blerta Maliqi, I work for the World Health Organization in Geneva, and the WHO in Geneva is the part of the organization that is in charge of setting norms, standards, and policies. So basically, I do everything up to here. I'm not going to repeat any of the things that have been said, not because they're not important, but because they are exactly the same challenges, lessons, pains we go through with every single thing that we produce. So prioritization, who prioritized? Member states prioritized, it goes through processes, it comes to the assembly. Then we as Secretariat get directions to generate or to gather the evidence, to put that evidence through what we call evidence to policy funnel, to sniff it through, to identify what works, doesn't work, to get the evidence into that kind of ranking and say, this is the best type of guideline standard of policy, and then go to the world and do what we call implementation, which is the following. We advocate for it, We conduct policy dialogues with stakeholders, with countries, with groups. We build capacities of partners, of member states, of everybody who's in charge of implementation. And of course, we monitor the implementation. And this is what we do. So thank you, I'm done. I'm sorry, it's 5 o'clock, we have to go to a party. But Karen, she had a different opinion. So she gave me the last in the panel to speak about what works, what fails, and how to do better. So now, rewind the story and let's start from the beginning. 2014, the world was very concerned with the Millennium Development Goals, MDGs, if you recall. One of those was maternal mortality. So some countries in this room are the guilties for improving coverage massively during that period, 2009-2014. Ethiopia being one among them, with very innovative changes in the way on how they approach the front line and assisting women to deliver, now with somebody who was called a skilled birth attendant. Saying that, coverage shooting up, mortality, morbidity not changing. So then there is a group of wise people. Many of them should have been in this room today. I'm sorry they're not, because they come from what it used to be USAID and PEPFAR and other organizations. So the same group of people came to WHO, and in a very little meeting room, they said, listen here, we have been spending the last 20 years, or spending money in the last 20 years and investing ourselves in the last 20 years, trying to address this gap, because we think the gap is at quality. It's not about just coverage, it's what you get when you get into that birth room or into that provider. However, those types of interventions, while they are working very well as long as we're present, as long as the funding is there, the moment in which we take off, nothing is sustained, nothing is scaled. So we have multiple problems. We have one problem, which is quality of care is an issue. What do we need to do besides just improving coverage? Second, how do we sustain and scale these types of improvements, which we know that they work if you do just a QI, if that is the method, but they don't sustain and scale up. Fantastic question for WHO. So let's get the evidence, let's get into what is the policy, and that translated into what became the standards for improving quality of care for maternal and newborn health. So that is the policy, and that is where the story should end for today's story. Is it so? No, it's not like that, because in 2016, then everybody came together and said, we have to implement it. How do you implement? We did 2 consultations, bringing brilliant minds around the table to discuss implementation. And nobody came into an agreement. There was no agreement about how do you implement standards for improving quality of care for maternal health. Because everybody has a theory about how you go about implementing. But does it translate into impact? Does it translate in sustainability and scalability? And at that moment, that is when you have a better idea, which is that, okay, let's find those who may know better than us. And who may know better than us is the implementers themselves. How do you get to the implementers? And that is something, one of the key lessons learned. You need champions. You need people who believe, people who are committed, people who don't need to convince about this work. It's about this is important and needs to be done. And in this case, you need champions, which are policy and policymakers champions. The way and how we identify them, it was through ministries of health. So ministers of health of 10 countries that became the network for improving quality of care for maternal, newborn, and child health. Those ministers, they had committed brilliantly before, but they committed during this period as well by saying clearly in their national strategies or policies or in their national commitments that they were going to change maternal mortality by improving quality of care. They didn't say how, but there was this commitment. So we had a very strong starting point. Political commitment. That was one of the givens that everybody agreed about, that to make a change, to have an impact, you need that kind of political commitment. What followed were 6.5 years, COVID part of that, of implementation, 7 years, in terms of getting all countries together, trying to identify what was the path of that implementation. How do you shift from commitment that is about quality in general into something that is very practical at the front line? Partnership and partnering was the second big given in this combination. It was a period or time, it sounds so strange to talk about it now, in which partners were active in the ground, but having the government on the driving seat and then having partners supporting that implementation, being able to align and harmonize their thinking and their tools, that became a second element of the implementation. And the third, and this is the yes and the no, is how do you implement such a thing? Do you implement standards for improving care as a vertical program? Yes. If you want to see change, do it vertically. Or as a systemic, because that is when you get the sustainability and scalability. Yes, it's a systemic. The group agreed, or the countries themselves agreed that they didn't want to go vertically. We asked the question to 340 people who gathered in Malawi in 2017. And there was only one answer. We don't want to implement a vertical program. We don't want to implement a pilot program. It was even called it pilotitis. That was the wording that was used. We would like to strengthen the system to do this implementation. We are here, we're championing, important, we're a partnership, important, but we would like to go our own way. So each country had to chart its own pathway. They came with something that was very easy to understand for the politicians, not the policymakers. So instead of going with another framework of health systems, they chose to say leadership, action, learning, and accountability for quality of care. I mean, who doesn't like, I'm leading, I'm accounting, I'm acting, I'm learning. It's very easy to. That underneath it was exactly the health systems performance assessment that we discussed the other day and the implementation. Different countries, different contexts, different challenges. Where we succeeded, it was in getting all these countries embrace what didn't exist at the time, which is quality strategies and policies. This is pre-commission. Commission came and then after clarified everything. But when the things didn't work as well as we thought, it was in bridging that gap between the implementation or building the bridges between implementation research, which is adaptation. You need to adapt whatever you are putting in place. And then getting that, again, back into the policy. Why? Because we talk about it. We expect governments to have structures in place that can assure this type of going back and forth between adaptation, implementation, adaptation, improvement, learning, coming back, going into scale everywhere. But the governments, especially those governments we were engaged with, and perhaps the situation may have changed as we're speaking now, they don't have institutions or structures in place that allow for this facilitation that we would summarize with one word, learning. So it's not only learning at the point of care for improvement, it's learning for the system on how to go about it and appreciating that learning as an integrated part of the health system. So fast forward today, there are 10 countries that have achieved quite a lot of milestones in terms of policies. They have shaky outcomes in terms of improvements, long-term improvements. But we do see nowadays that there are some of the packages of interventions that they chose to improve, they are being scaling up. Are these countries suffering because of the donors or because of partners going back? Yes, they are. Do they have, in this moment, do they have infrastructure in place or structures in place to take this type of work forward? Yes, they do. So I raised my hand, verticalization works. That works very well when you want to see the outcomes. However, the systemic work is slow and is slower, but it gives you the type of sustainability that will provide the scalability when it comes. Lesson learned, you need champions, you need the partnership and alignment. You need to have a real goal. You don't have to go just without a goal. We did have a goal and the goal is still there. And working together between the programmatic or vertical with a systems approach or systems that embrace that type of programmatic approach is as important as anything. I can go in gaps, but I leave the gaps for the others.
All right, thank you. That was an amazing overview, and a lot of the questions that I was writing down up here, you guys kept answering as you went. So one thing that I've noticed over the course of the day, but also I think a common thread here, was that, well, we often talk about the what and spend so much time in the what of the research. All of you really talked about the who, and who are the stakeholders, and who's at the table, and how do you communicate, and all those pieces of it that are really crucial to doing something once we have this magical what that we all think should be implemented. So maybe if each of you could briefly share, a key lesson learned, but really reflecting on that not the what of the research, but the who and the how of bringing people together that you all have kind of referenced in your examples.
So I guess I can start, because I think some of the formative work is really understanding, and I think it's, we've sort of talked a lot about the champions. I think we've talked less about the community, and I think that is sort of one of the key things, is understanding, who is it that we need to convince that this is a good thing to actually get into place, who actually understands how to actually do that. And so thinking about the community, the provider. We have very nice terms for that about acceptability and adoption and feasibility. So thinking about who you need to talk to about actually being able to do that, and what is their own idea that this is actually something that is important to actually do. And so I think when we think about, for example, we're doing work looking at integrating hypertension, improving hypertension care and primary health care in Botswana, learning from work that a lot of people in this room have done. But really, going first to saying, well, in the community, like, do you think this is important? And they may say maybe yes, but it could be, well, yeah, but actually what we're really worried about is malnutrition, or we're really worried about some of these other things. The second is asking the providers. We're all of a sudden asking these very overburdened providers to say, this is something which is a slow change, not a fast change. So you treat somebody with malaria, they get better, very exciting. Treat somebody for hypertension, it's going to take a while until you actually see this thing. So understanding what is their motivation, what is their understanding from the systems perspective. So, are there systems in place to actually do this? And then very importantly, obviously from the policymakers, the politicians, and it's not just the Ministry of Health, it's the Ministry of Finance that you really need to get involved to understand who are the people who are going to say, is the what going to actually be put into place? And then I would say in addition to the who and the what, it's the how. That needs to be done.
Other folks want to jump in?
So first I'll say information overload is real. Not every publication needs a webinar. We should really try to figure out who our audience is for each piece of evidence and data that we're trying to get out there. And then based on that, then we figure out, well, this is what our dissemination plan looks like. I guess that's more of the how. But I think one thing that we sometimes forget in the research community is the importance of community. So if I am producing a paper and I don't have that lived experience, I better get on the phone, I better meet with the people who do. So really talking to the organizations who are working with these communities on the ground, because not only are they going to give us really valuable insight, but when it comes to dissemination, they're also going to help us get the word out and it's a two-way street. So not forgetting about the people who actually are being the most impacted and talking to them as we conduct our health policy research, sometimes in this ivory tower that we sit in.
In terms of who, in one of the earlier panels, Ross Bronson was a panelist, and one of the ideas that I stole from him is he talked a lot about designing for dissemination, which is this idea you don't want to wait to the end of a project and then think about how you're going to disseminate it. And since we're talking about the end thing we care about is impact, we now talk about designing for impact. But here's the thing: if you're a policy researcher, often you're very good at saying what is the research question you're wanting to answer, but it may be harder to look down that road and say, well, what is the impact that I hope this work will eventually lead to? And that is where the who comes in. We need the humility to say, well, the important thing is what is the impact that actually, you said something very similar, that matters to communities. When we worked with organizations, tobacco control organizations, this is about 20 years ago, and their funding was being cut, we talked to them and they said, it's not really just the money. The real problem is the uncertainty around the money. And they said the fear of having our budget cut freezes us much sooner and much earlier. We can't do anything, even though we actually still have the money. And that was, for me, an early lesson in sort of reframing from, in this case, tobacco control organizations' perspective of what really mattered for them in terms of impact.
So, as was said about community, often there's this idea that it's very extractive for researchers to come in and extract information from community and then never come back and disappear. We also see that with researchers and safety net institutions, such as our federally qualified health centers. And so one of the things IHN did establish is it's called the Network for Community Academic Partnership. NCAP, it's lovingly referred to. But it is the healthcare safety net here in St. Louis finally saying we're tired of academia researchers coming after they've gotten their grant funded, after their research proposal's been approved, and saying, open your doors and let us study your population. And it's asking academia to come to the table before the grant is submitted to help develop that in partnership, to run it by, get input and feedback on the ideas. And one of the things, and so I say that as part of the who. And then to sort of build on that, one of the examples is, and IHN has partnered with WashU, I think it's wrapping up now. There was an NIH grant where we were studying a model of group prenatal care, and specifically the impact of group prenatal care on the African American community. And good news is that it's highly effective as we wrap up that research. But two, it went through this process of working with NCAP, with the health centers, launched and piloted both in a hospital system, also within a health center, Affinia here in St. Louis area. And then the other who, I will go back to the importance of not all policymakers are politicians, because before the NIH study is even done and submitted and published, Missouri is now reimbursing for group prenatal care in its Medicaid program. How did that happen? It happened by an administrative rule through the Department of Social Services, because the director of Medicaid, the director of Medicaid transformation are passionate about maternal and infant health care. It did not require a legislative process. It required an administrative change and just working with the department directly. And we were able to make that happen with partners, not IHN alone, always in partnership. But it's an example of who getting policy done. It is not always the politicians. That it's in this environment, if you have to go legislatively, it's a difficult road these days.
Agree. That's very good for me. It depends on what is that you are discussing, and that I'm saying it because if I see it from my where my own job is it about discussing the global priorities for the next 20 years and then who should be around the table? Is it about developing the new treatment guidelines for anything and who should be around the table? Or is it about adaptation, implementation of a guideline or a policy that is already developed, and what does it mean for my country? Saying that, it sounds very different. However, when it comes at the end of the day, it's very similar. You'd like to have around the table those who are going to act upon and those who are going to be impacted by whatever the policy decision is. So, and that takes you immediately into, is it about health providers? Should they be around the table? Or is it about the policymakers because they have to adapt? Should they be around the table? Should they both be around the table? Most likely, yes. But for sure, you need the user at the end of the equation, whoever that user is. And that is important. I'm not going to map everybody around the who should be in terms of what it means. But when it comes in terms, at least from an evidence-based, you'd like to have the content matters to be around the table. Those who are independent, those who are acknowledged, those who know something about it and can guide technical discussion. You need the policymakers and the politicians around the table because they know how to communicate, what to communicate and how to communicate for what purpose. You need the professional organizations around the table because a lot of decisions we take are going to influence the way on how things are done by those technicians. You need the academics around the table because it's not only about who's going to do the job of research and translation, but it is about what are those critical questions that we need to ask and answer, which will not going to be asked or answered if you don't have an academic with a very critical mind and independent mind sitting there. And I can go on and list, but I would like to add one element that I didn't hear it so far. You want diversity around the table. You don't want to have only one group, one race, one nation, one gender, one age. You'd like to have diversity that is a notion of diversity that goes beyond only stakeholders. I mapped stakeholders very nicely, I can go on. But you'd like them to be balanced in order to get those points of views which you'll not be able to get if you don't bring that discussion up front in the debate. Thank you.
Thank you. Now, I could keep asking the however many W's there are, the where and the when and all those things, but I will stop myself and open it up for questions in the audience. We've got about 20 minutes for folks, and so please raise your hand. I saw someone start to raise their hand over here. right here.
Thank you. Wonderful. My question's on the sort of communication between the community and the champions, and then the sort of policy side. So what I heard was sort of a lot of this conversation is around, as was described over here, the policy is kind of made, and then now we have to implement it, and there's that question of implementation. And so I guess in my setting, we work a lot with doctors, and so I'm on the analysis and modeling side. And when we ask physicians who are working on a particular area, endoscopies or whatever, we figure, well, we ask them, what are your problems? And they'll give us a list of problems. But I also think like sometimes what we found is that the problems that they say are the problems that they see, which are not necessarily the problems that are impacting the system as a whole. But they might be. So I guess my question is around that like interaction, not just the sort of top-down flow, like here's a policy and then how do we implement it, but also kind of the reverse flow. How does the knowledge of the grassroots or the knowledge sort of influence the policy itself in ways that actually maybe allow the community to grow in their knowledge? So they may have an initial assumption that says this is the problem, but then through the sort of interaction, several of you use the term system science. How is it that using those methods can sort of help change the minds of the people to bring them sort of more in agreement with what the real problems are? But maybe that was already discussed, but that is on my mind.
Anyone want to take that one? System science was called out, Doug.
There is, there's a lot there to unpack. So let me just latch onto one part, which is the system science part, and talking with policymakers. System science sounds complicated, and it can be, but I know a number of you in the audience use tools like group model building. And there's a phrase, group model building as an intervention. And the idea of that is by having partners go from the beginning, work on this, it's not just buy-in, but there is that growth in understanding. So if they're part of this process where a diverse group is gathered together to map out a complex system, then the communication happens as a natural part of that. You're not just showing a picture at the end and having to walk through and explain what this means. It's a picture they created themselves. And so system science produces a lot of things like this, maps and visualizations that are all about the system that people live in. And so it's a very useful tool, even though it sounds academic. Systems methods are useful tools for working with all sorts of partners.
It's not going to be an answer to the question, but I'm just going to flag one thing that has been identified that is lacking in most systems in the world. During COVID, we tried to understand how health systems were reacting in order to maintain the essential service delivery in place, etc. And one of the gaps that we identified was that while we were all very good in working with quantitative data, meaning health information systems, routine information systems, we killed them, like Excel sheets and sending. But when it came in terms of the tactile knowledge of people's experiences and what was working or not working for them, and getting that to feed into the same way and to be discussed in the same way as those quantitative numbers that we're looking at, we didn't have that channel. We don't have yet that channel. So by the end of COVID, all of us, and Suzanne Karai is sitting over there, she was part of the same discussion with us for 3 years. And we said that health systems have to change. We need to create the forums, or we need to create the mechanism to collect the voices, not just people's voices, as Margaret has already jumped that bridge, but voices that come from the system that need to be heard in order for us to improve and not to wait to identify the question to go, et cetera, et cetera. If anybody knows about any country that has thought about developing an intelligence, I call it intelligence system, that goes beyond talking numbers and beyond only annual reviews that are only very well organized into something more organic, that would be great. And perhaps those would be elements of learning systems that we are looking for, but we have not yet started to develop.
I feel like I should say something, but it is such a complex, there's so much there to that question, because yeah, I mean, yes, from IHN's perspective, we believe in the bottom up sort of, I don't even like bottom up, but the community informing the issues and what are the issues and what are their experiences. And the challenge I have with the question is community is not monolith. And so that makes it really complex because like we often, and we have to categorize groups in order to do science. But like the Black community in St. Louis is not monolith. Like the opinions and the thoughts and their experiences are not monolith. And so that's where the challenge comes in, where we are trying to pull that apart in different ways. And I think, you know, like our NCAP table, it's community providers. As you said, it's the providers that are providing care, and they are reflecting what they hear from their patients, but their patients are one subset of the population. And so how do we, and I will give an example of this is complicated work, and when you hear multiple opinions and as a researcher, that qualitative stuff can drive you nuts. I get it. Because you're hearing different things and you're like, just leave me alone and let me study the data. But I will give the example of, we are currently working with WashU with a new federal agency, ARPA-H. It's called the NITRO grant. It's focused on osteoarthritis. And one of the things the previous administration at the federal level was interested in making sure happened was that different community demographics were reflected in the study. And so what we know about osteoarthritis is most of the study has been done with white Americans. And so what IHN's role was in that research, or is, because it's happening, is the community engagement part. And so we have been doing a series of focus groups specifically with patients or caregivers impacted by osteoarthritis, but then also doing focus groups specifically for African American focus group, a Hispanic focus group, a Native American focus group. So it's complex, it makes the process longer. The researchers at WashU don't necessarily love the information we're providing back, because it's messy, but the messy is often where you really find some answers that will make a difference.
Want to just also point out, because this is the science for health systems, and so I think there's sort of some tension, and it's perhaps a request, or maybe how do we actually make the qualitative work we do more nimble? Because this was a discussion that again came up in the World Bank session, which is IRBs sometimes often just kill the ability to do anything in sort of a relatively rapid time. So how do we actually help people understand this is to actually think about a policy, how to get it into place? The primary goal is not research, obviously different than if it's a federally funded grant to actually do that. But how do we actually, is there roles for AI? Has been very, rapid ways of doing this. So how do we actually, in the same way that you can very easily sort of get data now from these health information systems, what are the methodologies that we actually need to do in the next year or 2 years or 3 years to be able to make the qualitative work as nimble, so that you don't have the researchers sort of rolling their eyes or the policymakers saying, well, talk to 5 people and then come back and tell me about it. So I think that's just a challenge out there. I was originally a quantitative person. I've become a dedicated mixed methods person, but for those of you doing qualitative, how do we actually do this in a way that is quick so that people view it as a must-have, as opposed to, gee, that would be nice to have, but I don't have time for it.
Any other questions? Yeah, go ahead, please.
University Xiaolin Wei from University of Toronto. So my question is about how we can make research impactful for policy in a difficult situation. For example, I would turn the question like Dr. Maliqi, that in many countries there are different times. Countries might be in a war zone. Countries might have other priorities. Countries might be in a political turmoil. And then we still need to push the work forward and make it work for maternal child health, for example, and how you have conquered that difficulty. And also I want to ask the people from the United States, and when you face a very difficult policymaker as currently, and how can you do, specifically like CDC, the vaccine policy, etc., the measles outbreaks, and we do want to make the research impactful, even at a smaller scale, as a good example, but how can we achieve it? Thank you.
Great question. Anyone want to jump into that one? Policy impact in difficult times.
Well, policy and fragile. Yeah, good question, difficult question. I'm not the right person to answer, but I'll give my opinion about the question. You expect, it doesn't matter what the conditions are, you expect people to be served. So that is something that we all here in this room have. So if today there is a hurricane outside, we'll still expect that tomorrow, if we are going to have a diarrhea, we'll get the pill or we'll get what we need, and then it will be done on time. So when it comes in terms of fragility, and that is how I'll call it, fragility or vulnerable conflict places, we do have different approaches. So those that are protracted crisis, many countries are fragile and don't have the means. There still is a basic, we are expecting to see a basic package of services in the basic conditions being provided, people being served within their own context. I'm not going to list countries, it's not nice to list, but then we know that there is an essential package of services that I'll call that as a basic policy that you'd like to see in place. Different situations, if you have a tsunami and immediately after tsunami, how do you go about that? You still have a basic package of services that needs to be in place and a way on how you can respond to that type of emergency. There are other emergencies like a war zone. So I'm not an expert on war zones and how to go about that. But even in that condition, you still are expecting to know how to operate this network in order to serve people who are there. Let's take maternal and child health. I'm sorry, but a woman cannot keep the baby beyond 9 months. I mean, you cannot postpone your birth to next year when there will be peace. So there is something that needs to come with. Does it mean that there is an evidence-based policy implementation in fragile context? Yes, there is. Where does it come? It comes, I think, not only from what I would have described, for example, during COVID, that the guidelines during COVID didn't change in terms of treatment. The conditions in which the treatment was provided changed, but the guideline was exactly the same guideline. So a woman gave birth with exactly the same type of service that needed to be there under different conditions, but in the same way. So I would say that yes, there is a clear guidance and policy and what needs to be in place for each condition. The way on how you apply it has to respond to that context. But I think by now we do know quite a lot on how to respond to those contexts. Yeah.
There's another question up in the front here. Sure. Does anyone want to take that one? The second half of the question.
I'm happy to. So we don't normally reach out to tougher politicians because we know that's likely not a good use of our resources. But what we do at times is if we're having a convening in Washington, D.C., we make sure that that people from both parties are being represented. That's really, really important because even if we can't personally go speak to someone who's a bit tougher, their colleagues possibly can. But then I think there's also, we have to do a little bit of forward thinking in our research. So we know something's happened, even if we don't agree with this policy change, what do we think the world's going to look like in 5-10 years, and what kind of research do we need to put in place, whether we do that internally or we provide a grant to someone to understand what the impact will be, to model the impact for the future or whatever that may be. So it's because when that time comes, when we do have the evidence and we do see what the impact is, we are ready to go, we're ready to put it out to the world. This is what's happened, this is what we predicted. Please, let's make some better change.
Question from?
Yeah, thank you. That's in fact a multiple streams model you just related. But I was challenged by what Dr. Maliqi said. Can you give examples of where people can feed back to policymakers on how the system functions? I do think the examples are there, plenty, but indeed at local level in learning health systems. And I think here of the examples we have from UK, from the Netherlands, from Belgium, where we have set up local systems with local accountability. And actually there we learned reciprocally from health systems in sub-Saharan Africa with district health systems and community health representation. And in Belgium, where I was part of guiding that process, what worked very well is having care councils which had delegated authority, but they had to set up network governance with clusters of health providers, social providers, and patients or healthcare users, whatever. They had very complicated names. And empowering all these different clusters and bringing them together really helped making a structure. And that we were lucky in a way that we started it out in COVID, where there was a very much a shared sense of urgency and a task which we could do all together with these different groups. After COVID, it took time to find a common purpose. And you could see that in that network governance, you had pre-organized parties which were a bit better than the patients, which were more loose ends. But studying that process, we learned a lot about the mechanisms which actually make such local networks work. So yeah, I do think it's possible, but closer to the people.
I'm going to take the last couple minutes here and just ask everyone for one sort of final comment that you'd like to leave the audience with in terms of how do we do better in policy translation, and what would you like people to leave the session remembering from what you said?
I think, sort of thinking back to the simpler times, you'd publish your paper and you'd say, oh, go forth and change the world. And I think there's luckily been a recognition that has to do. So I would say, from my perspective, it's figuring out how to actually sort of value and support the kind of conversation that sort of goes down this pathway so that people can learn that. I would say the second thing is, I know when I got my MPH, nobody ever talked to me about policy. Actually, there probably wasn't much qualitative research either. But thinking about how do we actually train the next generation as well to sort of value this, as opposed to it being sort of it's the verticality of how we think about research. And so instead thinking about how do we think this is really a multidisciplinary approach that goes all the way from the beginning of the thing that comes out of the lab as the most efficacious thing, through effectiveness, implementation, research, into policy, and then into practice.
I would say be nimble. Times change very quickly, so you really need to adapt with the times, and that may be in terms of the people you talk to, the type of research you do, the type of publications you create. But if you're not changing with it, then you're going to continue to write 200-page reports that policymakers just don't have time to read.
I got into policy research because I wanted to do work that might have some impact. And speaking to the researchers in the audience, especially young researchers or younger than I am, have the courage to think about the impact of your work. We get that trained out of us. And it makes your work better if you look down that road and see where your work will make the world a better place. That's why we got into this field in the first place.
Yeah, so I would leave you with, so I got into this, I started my career as a clinical social worker, and I worked with homeless kids. And still to this day, I have a picture of one of the young ladies I worked with that was murdered by a serial killer in Portland, Oregon, when I was working with her. And it changed the trajectory of my life. I was like, I cannot do this anymore. And the system is so screwed up, and we failed her. As a society, as a region, whatever. And so that's what got me into policy and systems change. And I am a data geek by nature, and I love the data, and I love digging into it. But what I've learned over my career working with policymakers is you have to be able to boil down your message of what you're trying to get across, I mean, literally into less than a 5-minute elevator speech, or like 3 bullet points, just to get people's attention, and then know your audience, because there are folks that I would say are policymakers within departments that are going to be much more interested in digging into the weeds and getting really geeky with you. But the effectiveness is really dependent on the audience you're speaking to, in terms of being able to talk about your research in a way that is understandable in plain language is so important. And I would leave you with keeping community, keeping the people, keeping the reason you're doing this work at the center of your work. Your passion comes through, and it's okay to be passionate in this day and age. And I think that's vital to pushing us forward to changing systems.
Agree. I had one point, but somebody stole it from me. I would say pick your battles. Make sure that what you're picking up is what matters, and that is the impact piece. That's why the impact was stolen. Pick the battles, pick those that matter, and that what matters is the thing that has an impact. And for that, you need to be brave. So that is one thing I've learned in the last 30 years. If you're not brave to point to find out what is not working for the purpose that is meant to work, then you need to build up your facts and you need to bring and to do everything that is being said. But I'll say pick what is important, that has an impact, and don't shy away if it is worth doing it. Yes.
Thank you all. Those are wonderful words to end on. And just everyone, please join me in thanking this amazing panel.